So the next thing that we want to talk about is ET versus supraglottic, biad. Of course, that's always been a big contentious thing in the pre-hospital because, well, paramedics want to do that intubation. But just talk to us about the effectiveness, the research, what those things are showing.
Well, again, I think that this is a prime example of research driving clinical practice. When EMS was first started in the state, and nationwide, one of the biggest, I guess, changes in thinking at that point in time, can we take paramedics and train them in procedures that have been routinely performed by physicians, and one of those was endotracheal intubation. And the answer was yes, we could do that. As time has evolved, one of the things that I think has come into play is, are we really helping people with endotracheal intubation now that we have biads or supraglottic airways, whatever terminology you want to use? Now that they've come into play in the pre-hospital arena, are there better ways to manage that airway than endotracheal intubation? And I think the answer is yes and no.
Sure.
I think that the research is showing that the clinical outcomes, long-term outcomes, are better with supraglottic airways than endotracheal intubation. There are certain instances where endotracheal intubation is needed. Airway protection. Biads don't really protect the airway. There are some times when you need to protect the airway. If there's a burn, patients got a GCS of 6, they are not tolerating a biad, but they will tolerate an ET tube if we can RSI them. I understand we're not RSI them across the board, but
Sure.
there are some services that are doing that.
Sure.
So there are some cases that endotracheal intubation are clearly needed, but I think the studies are certainly pointing toward the direction in that in cardiac arrest, non-traumatic cardiac arrest, then biads are leaning toward a better clinical outcome than with endotracheal intubation. There was a study that came out several months ago by our colleagues at UAB, Shannon Stevens, Randy Gray, and those guys, that have clearly shown that as part of the PART study, the Pragmatic Airway Resuscitation Trial, that the findings of that trial showed that biads, supraglottic airways, especially King airways, were certainly superior than endotracheal intubation. Now, I have my own personal observations of why I think that we have seen that endotracheal intubations are not lending themselves to good clinical outcomes in cardiac arrest. I think one is that we have a dilutional skill set, and many people ask me, well, what do you mean by that? And I'm going to take Tuscaloosa for instance. On a cardiac arrest in Tuscaloosa, you very well may have a pumper with a paramedic. You may have, obviously have a rescue truck with 2 paramedics. You have a North Star paramedic. You may have a North Star supervisor. You may have a Tuscaloosa fire supervisor, battalion chief, EMS chief, etc. So you've got sometimes 7 or 8 paramedics on the scene. One paramedic may intubate today and may not intubate again for a year. And we looked at it several years ago out of Montgomery, and 95% of the intubations in this state at that point in time were done by 5% of the paramedics. So 95% of the paramedics were doing little to no intubations. And it's not like riding a bicycle. People talk about, well, I've intubated, I cannot intubate forever and still intubate. Well, maybe so, but you may not be as proficient at it as you were when you were doing it very frequently. So I think that's one of the things. We have a delusional skill set. 2, I think that if you look at the studies, many of these people are getting intubated, but it's taken them 3 or 4 times to get intubated. That's interrupting CPR. That is, decreasing their cerebral perfusion pressure because they're not getting CPR. They're becoming hypoxic, so they have an anoxic brain injury. So I think those are things that my observation, and I think the studies are basically bearing those same observations out as well. So I think long term you will certainly see more emphasis on cardiac arrest management from an airway standpoint of our supraglottic airway. Now, as you know, in Tuscaloosa, I instituted this several years ago that I wanted them to attempt intubation one time on a cardiac arrest, and if they did not get it, they went straight to a BiAD.
Sure.
And I think many medical directors of services are doing something similar, or not even allowing intubation on cardiac arrest, going straight to a supraglottic airway. So I think that will be another area of research and an area of critiquing every day what we do from a cardiac arrest management.